So thank you, Jan, for the nice introduction, and thanks to the Purina Institute for inviting me. So we'll start with a little background why I am giving this talk about switching from antibiotics to more microbiota-friendly treatments for chronic diarrhea in dogs. So I'm Swedish, and I worked in Sweden through most of my career. And Sweden is one of the countries in the world with the lowest prescription rate of antibiotics and the lowest antimicrobial resistance rate, because that goes hand in hand. And since 1992 to 2016, there was a 43% reduction in antibiotic prescription in people. And this was not just by luck or good fortune. This is the result of systematic and strategic work, much thanks to Strama, the Swedish strategic program against antibiotic microbiota resistance. And if we look at the veterinary sector, the antibiotic prescription has significantly decreased since the mid-80s, when antibiotics were banned as a growth promoter in 1986. And in 1998, the Swedish Veterinary Association's policy on prudent use of antibiotics was published, and you were supposed to follow these guidelines. And then in 2002, specific guidelines on the use of antibiotics in dogs and cats were published, and these have been updated twice. And in 2016, guidelines on using and dosing antibiotics in dogs was published by the Swedish Medical Product Agency. And these ones are a bit more detailed than the other ones. So what does this really mean in numbers? Well, we have looked at almost 100,000 consultations of canine gastroenteritis in Sweden during 2020 to 2016. So these cases were all within Evidensia, which is the corporate branch I'm working for. And we looked at both acute and chronic gastroenteritis. So the yearly mean rate of antibiotics for canine gastroenteritis during those 4 years was 5.7%. And this is really low compared to international publications from other countries, where something around 41 to 70% prescription rate for chronic or acute gastroenteritis have been published. And that is way more than what we are supposed to prescribe. And the good news is also that during those 4 years, there was an over 50% decline in antibiotic prescription, and the mortality rate didn't increase because we looked at that as well. So this is an abstract that was presented during the ECVM Congress in Lyon earlier this year. And if we look at chronic gastroenteritis, there was also a decline. So in 2020, the prescription rate was 2.4%, and in 2023, the prescription rate was 1.1% for chronic GI cases. And this is about the amount of antibiotic I prescribe, and I know that because we have antibiotic surveillance. So we get reports like every third month how we are doing. So I know that I prescribe antibiotics to from 0 to 2% of my clients. So now we're going to look at this a bit more case-based, and this is beautiful Ebba. Short-haired, intact female collie. She was 1.3 years of age when I saw her the first time, and I actually saw her for the first time this spring. She's had intermittent vomiting, diarrhea, and hyperexia for 9 months. And the first episode was likely stress-induced. That was when she was sent to a boarding kennel because the dog owners were going on holiday. She's been hospitalized twice for gastrointestinal signs. On both of those occasions, she has been dehydrated. She's had melena and really explosive vomiting. And she also had pancreatitis on one of these occasions. The vomiting has stopped after multiple dietary changes, but diarrhea has continued. Her appetite and activity level is okay, unless she has really severe flare-ups. And as I said before, she's had acute pancreatitis on one occasion, but it's not chronic. Her canine pancreatic lipase is back to normal and has been for a while. And you can see the Purina fecal scoring chart to the right. So when I see her, she has a fecal score of 6 to 7 out of 7. So it's impossible to pick it up. And she defecates twice daily, once to twice daily. And she's in a good body condition score, as you can see here. So physical examination is overall normal. She has slight abdominal pain on palpation of her intestines. Otherwise, she acts normally. Ultrasound looks completely normal as well. This is her dietary history. Initially, she was on a premium kibble diet, and then she went to an easily digestible gastrointestinal diet after the first episode. That didn't really work for her. The dog owners have tried a raw food diet based on moose and reindeer protein. And she's also tried a hydrolyzed soy-based diet, but none of these have really worked. She has continued to vomit, having hyporexia and showing signs of nausea. However, when the dog owners switched to a hydrolyzed fish-based diet, she stopped vomiting, but she only seemed to tolerate it in a canned form. And as you can imagine, that is quite expensive. Previously, she's been treated with omeprazole. That also made her show signs of nausea. And they have also tried psyllium, but she doesn't want to eat it. And now she's on metronidazole twice daily, and she's been on it for 10 weeks. So this is a rather rare case coming from Sweden. I'm sure you all see these cases quite frequently, but this was common like 15 to 20 years ago, but now it's really rare to see a dog having been treated with metronidazole for 10 weeks, because it's really against the guidelines we have in Sweden, how you should use antibiotics. She's also on prednisolone, 0.5 mg per kg every other day. She's been on prednisolone for 8 weeks. The dog owners tried to stop it at one occasion, but she started vomiting again. She's on a multi-strain probiotic every other day, and she's on sucralfate twice daily. So what's the plan here? Well, I want to stop antibiotics, and I want to stop the diarrhea, of course. And I also would like to taper and potentially stop the corticosteroids. I'm more worried about antibiotics long-term for a young dog and all the negative effect it can have on the microbiota. And the dog owners are very interested in switching her to a kibble diet, because this hydrolyzed diet is really expensive in canned form for a 20+ kilo dog. So how are we going to do this? My first plan is to add fiber, because she's never tried a fiber-rich diet, and there has been some evidence of stress-induced diarrhea. And then we discussed that if she didn't respond to that, we would try a home-cooked diet with a nutritionist involved, plus minus FMT at the same time. But the first thing I wanted to do was try fiber. And fiber isn't only for colitis. This is a study that was published a few years ago. They had 16 healthy dogs and 16 dogs with chronic enteropathy. And these dogs were fed either a hydrolyzed meat-rich diet or a grain-rich diet, and a fiber bundle was added to that diet. And the dogs were fed this diet for 4 weeks. And it didn't really matter if it was the grain-rich diet or the meat-rich diet. They had the same positive effect of the fiber bundle. So after 4 weeks of treatment, the microbiome recovered to some degree in the dogs with chronic enteropathy. So the microbiota resembled that of the healthy dogs much more than it did initially. And more specifically, what happened was that the intestinal microbiota, the diversity improved, so more species were present. Fecal scores improved, and the amount of short-chain fatty acids in feces improved. pH decreased, and the loss of amino acid decreased when the dogs were fed this diet. There's another cool study from Portugal in 22 police dogs. These dogs were labeled as having idiopathic large bowel diarrhea, but I think there was some element of enteropathy as well, and I'll show you this in a second. So these dogs were working hard, but they had frequent bouts of diarrhea. So the only thing that was changed for these dogs was that 4 tablespoons of psyllium was added to the diet. So they were kept on the same diet, but psyllium was added. And then the dog handlers had to keep a diary of frequency of defecation, fecal scoring, body weight, etc. And the response to this was excellent. So 50% of the dogs had an excellent or very good response to the psyllium. And this meant that they had normal feces. Sometimes they had diarrhea, but that was really rare. 40% had a good response, meaning that most of the time they had normal feces, but diarrhea episodes weren't really that uncommon. And then poor response was no response at all. The interesting thing here is that the median increase in body weight was 2 kilos, and that's quite a lot. So likely there was some degree of involvement of the small intestine as well. And the effect of psyllium lasted for 3 weeks after stopping the treatment, and then the clinical signs came back again, so then they were put on psyllium again to be stable. Another really cool thing about fiber is that we know that when we give fiber, good quality fiber to the intestinal microbiota, short-chain fatty acids are produced as metabolites. And this has been shown to lower cortisol stress response in healthy people. So this is a study from the Netherlands. They had 62 Dutch males, all were considered healthy. And then they were divided into 3 groups, and this is double blind, so of course they didn't know which treatment they were going through. The first thing they did was the Maastricht acute stress test. And this means that you put your hands in 2 degrees Celsius water for a period of time, and then you have to calculate backwards, withdrawing uneven numbers. And there's an instructor who tells you how really poorly you're doing while you do this test. And then you have to dip your hands in the cold water again. And after that test, the participants either were treated with short-chain fatty acids in capsules at a high dose, a low dose, or placebo capsules. And then the test was repeated again. And this time, the ones that had been given the short-chain fatty acids in capsules form didn't have the same cortisol stress response after they were exposed to the test again. So first you could think of that, okay, they've done this test once already, so it isn't as scary the second time round, but there was no difference in the placebo group. So it appears that short-chain fatty acids can lower cortisol stress response, and this could be one of the contributing factors why fiber can be beneficial for stress-induced diarrhea. So back to Ebba, I started a commercial multi-fiber prebiotic that contains psyllium, beta-glucans, mannan oligosaccharides, cellulose, and a few other fiber sources. And I tapered the metronidazole to once daily for over 4 days and then stopped it completely. The dog owner was really worried that she was getting worse when stopping the antibiotics. So maybe the melena would come back or the vomiting. So she wanted a just-in-case prescription, but I denied that because this is against the regulations. You're not supposed to prescribe antibiotics just in case. So she had to go with that, but if she was getting worse, we could prescribe it again, and I could try a more slow tapering of the antibiotics. But she had an excellent response to the fiber. Diarrhea stopped within days, and her fecal scores was completely normal, 2 to 3 out of 7, and she defecated twice daily. So after 3 weeks, with no worsening of clinical signs, she was really stable. I started tapering the prednisolone slowly. She has no side effects of the prednisolone at this point, so I'm not in a hurry here. And we've continued the pre and probiotics. So this is about 3 weeks ago. She is now almost 2 years of age. She's doing really well. She's full of energy. She's training hard. She lives on a farm. And her fecal score is completely normal. The only time she has relapsed with diarrhea was during a visit to Stockholm over the weekend. So Ebba is a farm dog. She hates the city life. She doesn't like tiny kids, and they were going to visit the grandchildren in Stockholm. So she had diarrhea while visiting Stockholm, but it normalized when she got back home again. And at this time point, she was on prednisolone 0.1 mg per kg every other day, prebiotics twice daily, so that's the fibers, and probiotics every day. And we have managed to introduce kibble diets without a negative effect. So now 50% of her daily energy intake is in the form of kibble diets. And we have a plan to stop the prednisolone, so she's now on prednisolone every 3rd day, and then hopefully she can be kept on only the fiber and the diet. So next case is Tyra, intact female Shar-Pei, 4.5 years of age. She has had loose stool or diarrhea for most days since over a year when I meet her for the first time. And vomiting started a few months ago, so she's now actually declining. She's getting worse. She has mild hyperexia, and she defecates 4 to 5 times daily. She's tried an easily digestible diet, she's tried a high fiber diet, and she's tried a hydrolyzed protein diet, and that hasn't really helped her. Her fecal score is all over the place, so anywhere between 4 and 7 out of 7. So good days, she has feces like 4 to 5 out of 7, and on poor days, she has fecal scores of 6 to 7. She's had several courses of metronidazole and she do respond to it, but she relapses every time. So within a few weeks after metronidazole has stopped, diarrhea comes back. So I do some workup, but first a clinical examination. She has a poor hair coat and she's painful on rectal palpation. I have to do that when she's sedated because I can only touch her when she's sedated. So she has cobalamin deficiency, she is really low in folate and really low in cholesterol as well. So she clearly has malabsorption. Albumin and protein is normal, but you can see that these parameters are low. So Tyra really fulfills the criteria for antibiotic responsive enteropathy. If we look at this old way to work out these dogs and treat them, and you all know this. So first thing, elimination diet or dietary trials. If they don't respond to that, the next step is antibiotics for 2 to 4 weeks. And if you respond to that, you have antibiotic responsive enteropathy. So yes, we can say she has that. And the third step, if the dog doesn't respond to antibiotics, is trying immunosuppressive treatment. There are several problems with this strategy. And this is clearly shown in this paper by Toresson and co-workers from, I think, Hanover. So they looked at 81 dogs with chronic enteropathy and sent out questionnaires to the dog owners, and they were followed for a minimum of 1 year. So of the dogs that were treated or tried these different treatment approaches, 56% responded to diet. Next step was antibiotics, and they were given antibiotics for 3 weeks. 14% of the dogs responded to that, and the next step is then immunosuppressant. And 28% of the participants responded to that. So actually more dogs responded to immunosuppressives than antibiotics. Well, the problem here is that 34 dogs were treated with antibiotics for 3 weeks, but only 11 out of 34 responded to it. So 23 dogs were treated with unnecessary antibiotics for 3 weeks. And actually the dogs that did respond to antibiotics could potentially have responded to other treatments as well. So you could say that, well, it's not that bad having 3 weeks of antibiotics. It's not the end of the world if you don't need it. And it's not, but for some dogs, this can have a long-lasting effect on the intestinal microbiota. So this is Sul. She's one of our fecal donors. This means son in English. So she's an intact female Nova Scotia duck-tolling retriever, 5 years of age. And she's a fecal donor. She has a really nice and high amount of Fecalibacterium in her feces. You can see here, this is part of the dysbiosis index, and the gray zone is the reference range. So she's really high in Fecalibacterium, and that is what we want from a fecal donor, because Fecalibacterium is very important for GI health. In February 2024, she developed a urinary tract infection, so she was treated with amoxicillin for 5 days. So we had to take her off as a donor because we can't have donors that has been treated with antibiotics. We have to wait a while. So after 7 months, we tested her intestinal microbiota again with the dysbiosis index and look at Fecalibacterium here. Fecalibacterium is 1.7. It's clearly far beyond the normal range, and she looks like a dog with chronic enteropathy. She doesn't have diarrhea, but I hope she won't have any type of insult to her GI tract because she will be less prepared to deal with that with this low amount of Fecalibacterium. But sooner or later, I hope her GI microbiota will recover, but it can take a long time for some dogs. So if we have these dogs with diarrhea, we treat them with antibiotics. Dog owner is happy, feces is back to normal, we are happy, we look brilliant because we've stopped the diarrhea. The problem is that we haven't stopped the diarrhea because these dogs that respond to antibiotics, they will relapse. In the studies by Elias Westermark and co-workers, 86% of the dogs that were treated with Tylosin relapsed within 30 days. In Susanne Kilpinen's paper, also on Tylosin responsive enteropathy, 88% relapsed within 2 months. And in Karin Allersbach's paper, 100% of the dogs that responded to antibiotics relapsed within 12 months. So what we have done now is that we have created the perfect metronidazole monster or Tylosin troll. And this monster needs to be fed antibiotics quite frequently because otherwise the diarrhea comes back. And this monster will also affect the dog owner because the dog owner will now be part of this monster craving antibiotics frequently because the dog owner knows this stops the diarrhea. But this is not a good strategy, neither for antimicrobial resistance, for the intestinal microbiota, and for several other reasons. And the problem is also that there are no studies comparing immunomodulatory treatment versus antibiotics for these dogs. So the true prevalence of antibiotic responsive enteropathy is not known. This is a very recent paper from Switzerland that was published this year. So they followed up 60 dogs with chronic enteropathy, and they were followed up for a minimum of 1 year. And they defined antibiotic responsive enteropathy as dogs not responding to food, not responding to immunosuppression. And guess what? 0 dogs had antibiotic responsive enteropathy. So we shouldn't go down that route if we can avoid it. This was shown by Fabio Colli yesterday when he was talking. So this is the old way. You do diet, then you do antibiotics, immunosuppression, and then there are some dogs that don't respond. This is now the new version, or at least Heilmann and Jürgen's version of the new the way to handle these dogs. So diet is the big one, and then you should go for immunosuppressant if they don't respond to diet or other more benign treatments. So avoid the dietary or the antibiotic trial. So back to Tyra, we did workup. This is a rather old case. We did endoscopy. She had moderate lymphoplasmacytic enteritis and colitis and moderate villus atrophy, which likely contributed to the low cobalamin and cholesterol and low folate. I started a novel protein diet with lamb and rice. She did slightly better, but it wasn't enough. So I started her on corticosteroids and cobalamin and folate supplementation. And 6 weeks later, she's doing really well. She has normal stool, she's much more alert, she has a better hair coat and a good appetite, and the dog owner is really happy. So now we fast forward to Tyra. So here she's 13 years of age, and she's under treatment with methylprednisolone 0.1 mg per kg every other day. So this is a really low dose. And she's treated with cobalamin twice weekly. I have tried to stop methylprednisolone on 2 occasions, but every time she relapses. But this dose is so low, so it doesn't impact her badly in any way, at least not what I could measure. So she has very low disease activity. She hasn't been treated with any more antibiotics for these years that have passed. She was euthanized at the age of almost 15 with severe arthrosis and cognitive dysfunction. So she did really well on the treatment I started on her. So the take-home message here is that dogs with diarrhea that respond to antibiotics, it doesn't exclude that they will respond to other treatments as well. So she looks really cute, and then she almost wanted to kill me. I could never touch her as long as she was alive. I had to sedate her. So this is Maltas, the third case, intact male German Shepherd, 5 years of age, really tricky to treat like many German Shepherds are. So partially non-responsive, partially immunosuppressive responsive, partially antibiotic responsive. And of course, he has skin problems as well, as many German Shepherds have. So he has had problems all his life. When he came to me as a referral, he was somewhat stable on high doses of corticosteroids regarding his GI sign, but his body didn't do really well on those high doses of corticosteroids. Poor body condition score, low muscle mass, etc. And also his skin thickness was really, he had a very thin and fragile skin due to the corticosteroids. Azathioprine had been tried to reduce the corticosteroids. He was on cyclosporine when I met him, as well as prednisolone. He's tried several dietary trials, 2 different types of gastrointestinal diet, a novel protein diet, and a fiber-rich diet. What worked the best for him was a hydrolyzed soy protein diet. It wasn't enough to control the signs, but his skin did slightly better and he was a bit more stable. To be able to reduce the corticosteroids, I switched him to chlorambucil, and that really helped. So he was on chlorambucil, and then we could start him on budesonide instead of prednisolone. So he became slightly more stable on that, but he still had flare-ups about 2 times per year that only responded to antibiotics. So he had short courses of tylosin and metronidazole twice yearly. And I thought that, well, yeah, okay, he's difficult to treat, so that's okay. But now things are going downhill. So now we are in April 2020. He is back for a scheduled checkup. He's doing worse. He has monthly flare-ups of diarrhea. He started to regurgitate, which he hasn't done before. And he's also showing signs of lethargy, which is new to him. And he's had 2 courses of Tylosin in 4 months. And I'm not happy with this, neither what he's doing or the antibiotics. So his maintenance treatment at this time point is budesonide 3 mg every other day, methylprednisolone for his skin, chlorambucil and cobalamin. On physical examination, he has marked abdominal pain, which he normally doesn't have. So it's not just that he's stressed to see me. This is a true finding. Clinical chemistry shows that albumin starts to drop for the first time in his life. Total protein has decreased more than albumin, and cobalamin is within the reference range, but really low, especially considering he's on cobalamin supplementation once weekly. We screen him for fecal parasites and he's negative. So now I want to do something different. And the dog owners agree to FMT. So we give him a cycle of FMTs, so 3 different treatments with 10 to 20 days interval. The regurgitation stops after the first FMT, and fecal quality improves after the second FMT, and he's much more playful than he has been for a while. And after the 3rd FMT, he has no more diarrhea, he has no palpable abdominal pain, and albumin and protein has normalized just by giving him FMT. Cobalamin has normalized as well, but that's most likely because I increased the dose of cobalamin. So his dysbiosis index went from 2.5 to -1 after the 3 different FMTs he had. So in January, 2 years later, he has mild flare-ups every 3rd month, and he responds to increasing the dose of budesonide. And these flare-ups last for 1 to 2 days, so they're quite mild. Serum biochemistry has been completely normal since we gave him FMT, no abdominal pain, he's not needed any antibiotics for 1 year and 9 months, so everyone is rather happy. February 2022, the neighbor's dog's female dog is in heat, and that makes Maltas super stressed, and he has severe flare-ups. So then we start a new cycle of FMTs, and they have the same positive effect as the first time. So this has really saved a lot of antibiotics from this dog. And Maltas is included in our paper on 41 dogs with chronic enteropathy, where we gave FMT as adjunctive therapy. And he had a very good response, and 2 other dogs was in this study that also needed frequent courses of antibiotics, and they also responded to FMT. This is a bit in contrast to this recently published study from Finland, where they had 14 dogs that had Tylosin responsive enteropathy, and they were split into 2 groups. This study was done during COVID. This is likely why the sample size is so small. So Tylosin was stopped, and the dogs were then treated with either FMT capsules based on body weight or placebo capsules. And this is double-blinded. And then they followed them during treatment for 4 weeks and looked at relapse within 4 weeks after treatment. So during treatment, there were more dogs with flare-ups in the placebo group, but when they looked at relapse within 4 weeks after treatment, then there was no difference between the groups. However, the group size is really small because they had to take out 1 dog from each group because of other treatments they had to give them. So the authors think that maybe this study is underpowered, and I can imagine that too, but I'm also thinking that maybe the FMT dose is too low. They had 1 to 2 capsules of freeze-dried FMT every day, and if you give rectal enema, you give a super high boosted dose of a very healthy microbiota and metabolome. And I've seen in at least a few dogs where we had capsules made from the same donor, but the capsules weren't as positive, the effect weren't as positive as if we gave rectal FMT. And I can imagine that is a question of dose. You can give much more microbiome if you use rectal enema. And quite common comment is that just give Tylosin because it isn't used for human consumption, so it's not a problem. So if the dog's microbiota develops antimicrobial resistance, that's not a problem. Well, the problem is that Tylosin is a macrolide antibiotic, just like erythromycin, azithromycin, clarithromycin, etc. And if antimicrobial resistance develops against Tylosin, then it quickly develops against erythromycin and azithromycin as well. So has this been proven in dogs? No, there are no studies on this as far as I know, but it has been proven in pigs. So this is a study from the US. They looked at 3 different pig farms. So farm A used tylosin as a growth promoter. Farm B used tylosin to treat disease, and farm C did not use tylosin at all. And then almost 1,200 isolates of enterococci was collected. And they looked at the percentage of erythromycin-resistant fecal samples in these pigs. So 2% of the enterococci had erythromycin resistance from farm C, 28% from farm B, and 59% from farm A. So this clearly shows that the more we use it, the more we lose it regarding antibiotics. And there are several studies showing a documented risk of household sharing of antimicrobial resistance genes. My colleague Ditte Ljungqvist was one of the first to look at this. So 22 people that had extended spectrum beta-lactamase producing Enterobacter or ampicillin C beta-lactamase producing Enterobacter were found. Those were mostly immigrants or people that had been hospitalized outside Sweden. They were not on antibiotics at this time point, and they had no clinical signs, but they were carrier of these resistance genes. So they were asked if they had dogs, and they found 22 matching pairs, so dogs in the same household. And then feces from the dogs was screened for antimicrobial resistance. And in 2 out of 22 households, there was sharing of antimicrobial resistant genes. This is a study by Belas and co-workers from Portugal. They looked at 20 households consisting of 27 people, 20 dogs, and 9 cats. All of them were healthy, but in 10 out of 20 households, there was sharing of antimicrobial resistant genes. And lastly, a study from New Zealand. So they identified 23 people, mostly elderly women, that had difficult to treat urinary tract infections, and that also had a dog or a cat. And in 2 out of 23 households, there was sharing of extended spectrum beta-lactamase or ampicillin C beta-lactamase producing E. coli between dogs and people. So this clearly can happen. This is a clear risk. And now for the 4th case. This is Elvis. This is a very old case. I would have done things differently today, but I didn't have the same tools at the time point. So he's a male Eurasier, and he has a lifelong history of chronic diarrhea, colitis, and hyperexia. He's had a poor response to gastrointestinal diet or fiber-rich diet, and he has refused to eat the high-price diet. He has a partial response to metronidazole, to corticosteroids, psyllium, and a monoprotein diet. He's on a salmon and rice diet, but flare-ups are quite common. And I've tried to taper and stop metronidazole several times. I'm not happy with prescribing it long-term, but he has increased disease activity every time. We've also tried azathioprine, and that hasn't really been helpful at all. But now we are in year 26, and the first Swedish cases of multi-resistant or methicillin-resistant Staphylococcus pseudointermedius have been found in Sweden. So now there's an increased focus on hygiene and also on antibiotic prescription. So now I have to tell the dog owner that I can't do this any longer. We can't go on with daily antibiotics. It's not legal, so to speak. So we have to try something else. So I add oxalisin. I decreased the metronidazole with 50%, and I tapered and finished metronidazole, stopped it over 12 weeks. And he had increased disease activity after every step of tapering, but it stabilized within a few weeks. So I didn't continue with the next tapering until he has stabilized. And 2 months after stopping antibiotics completely, he actually has lower disease activity with oxalisin and prednisolone than with metronidazole and prednisolone. So this actually worked better for him. And oxalisin has a local anti-inflammatory effect on the colonic mucosa. It decreases cyclooxygenase and lipooxygenase, and this is common therapy in ulcerative colitis in people. And this is actually one of my favorite drugs. For dogs, you use 10 to 20 mg per kg twice daily. I usually give it twice daily for 60 days and taper to the lowest effective maintenance dose over time. So typically I go down to once daily, and then after months, I go to every other day, depending on how the dog tolerates it. And you can use it with corticosteroids. The important thing is that it takes 6 to 8 weeks until it has effect, and it only has effect in the colon, not in the small intestine. Most common side effect in dogs is keratoconjunctivitis sicca, and this is dose related. So you need to check Schirmer tear test before you start the treatment. If it's low, don't give this drug. And then you need to check after 6 to 8 weeks and at every checkup, because for some dogs that develop dry eyes, it can take more than a year. So you're not safe just because they have passed the first 6 months. If your tear test is below or at 15 but over 12, you need to taper the oxalisin dose and recheck. But if it's below 12, you should stop the treatment and start cyclosporin ophthalmic ointment, because that stimulates the tear production to come back. Most of these cases, if they do develop dry eyes, the tear production can come back again, but you can't use this drug in the future. Worsening of diarrhea can be seen, but it's quite rare. It's more common in people. Increased liver enzyme has been described in people, and acute drug-induced hepatitis has been described in people. I've never seen that in dogs, but it doesn't mean that it can't occur. So lastly, I'm going to show this cool study by Stefka and co-workers. So they had healthy laboratory-reared mice. They gave them antibiotics and wiped out the clostridial clusters, so several clostridial clusters. And then they exposed them to peanut protein. So with the antibiotics, they have caused a leaky gut and loss of T regulatory cells and loss of immunologic control. So the mice now develops food intolerance to peanut protein. And this can be measured by increased body temperature when they are exposed to peanuts, and also IgA, etc. And then they took this step a bit further. So same setup here, the lab mice, antibiotics, wiped out clostridial cluster, but then they reinstated some of the clostridial clusters again. Exposed to peanut protein twice, but after they had reinstated the clostridial cluster, the GI tract was much healthier, and now they did not have any food intolerance to peanut protein any longer. And this shows what an effective tool antibiotics is regards to immunologic control. So a healthy microbiome is needed for immunologic control, and antibiotics have a negative effect on immunologic control. So lastly, how should we talk to dog owners about this? Well, education is super important, and you should adjust your vocabulary to the level of the receiver. So I always talk to the dog owners of my clients about the good bacteria and the bad bacteria, and that the biggest problem in chronic enteropathy is that we lose the good ones. So we lose the positive beneficial microbiota, and we need to try to take care of that. Giving antibiotics is a bit like wetting your pants. It can give immediate control, and it make you feel a bit better for a short period of time, but there will be a lot of problem afterwards. And also, if we're going to give antibiotics for dogs with chronic diarrhea, we really must inform the dog owners about the risk of antimicrobial resistance and sharing of antimicrobial resistant genes, because in many households, there are people who are extra susceptible to infections, like elderly or infants. And there's also been shown an increased risk of multiple chronic disorders if you use a lot of antibiotics. So my take-home message is to try multiple strategies before antibiotics, multiple dietary changes, pre and probiotics, FMT, immunoregulatory treatment, etc. And just because a dog with chronic diarrhea responds to antibiotics doesn't mean it won't respond to other treatment. And don't create and feed this monster, because it's you can't stop it once you have started. It's really difficult. And educate dogs and cats owners on antimicrobial resistance. And with that, I'm happy to take any questions.